Good evening, respected delegates. So for last 6 months, one of the very common question that has been asked by our patients is that, doctor, could I take the COVID vaccine? I have a history of allergy, drug allergy, asthma, or such thing. And they are asking that whether I am eligible to take vaccine or the COVID-19 vaccine is safe or not, while I have a history of atopy or allergy like that. So this is one of the most common question that has been asked by our patient. So this is an important case I'm going to present that can answer this very specific question asked by the patient. And the thing is that we always like healthcare seeking behavior of our patient, because that health care seeking behavior is one of the most important step towards a healthy life for our patient. And mostly this healthcare seeking behavior is absent while we are talking about something which is preventive, for preventive medicine. So no patient or healthy person will call me and ask me, doctor, what are the benefits of exercise? What are the benefits of yoga? What are the benefits of quit smoking? So they will never ask this preventive, very important questions. But this is the first time, I think, in the history, or we can say the recent history, that patients repeatedly asking their doctors that whether I am eligible to take COVID-19 vaccine in the background that I have some allergy to drug or some pollen or dust, or I have some atopic disease like asthma or atopic dermatitis or urticaria like that. So with that, this is the case. The title of today's presentation is A Patient with Drug Allergy Asking Safety of COVID-19 Vaccination, Evaluating in a Clinical Pharmacological Way, a Case Report. So I am attached with School of Tropical Medicine, Kolkata, and Allergy Asthma Treatment Center, Moulali. So this is the case. A 33-year-old female doctor presented to clinical pharmacology OPD at School of Tropical Medicine after 6 months of being eligible for COVID-19 vaccination. So asking for suitability after being eligible for 6 months, that I am having multiple drug allergy, whether I am suitable to take COVID-19 vaccine. So for last 9 years, there are multiple incidents of drug allergy with a few agents, few drugs. So we had taken the detailed history, and also the clinical examination was done at the clinical pharmacology OPD. So if we move sequentially the different episodes, which is very important while evaluating drug allergy history. So the first episode, she was diagnosed with temporal lobe epilepsy, 2012 January, and initiated with carbamazepine. After 2 days, developed macular lesions with severe itching. Carbamazepine was deprescribed. It was treated with levocetirizine, prednisolone, and calamine lotion, and subsequently rash was subsided by 5 to 7 days. But at that time, peripheral blood to determine whether she is carrying HLA-B1502 allele, not done. And it is now recommended to do the testing, specifically the HLA-B1502, before initiating carbamazepine, because carbamazepine associated Stevens-Johnson syndrome are very common in this HLA-B1502 allele subtype. Now coming to the second episode, 2012 July, she had faced another episode of absence seizure. So lamotrigine and levetiracetam was initiated. After 6 weeks of initiation of these two drugs, developed rash with fever. So workup was done for different etiologies of fever and nothing found. After 15 days of fever onset, she was admitted with hypotension in acute care setting. There were some foul-smelling discharges from different follicular areas of skin, specifically from the scalp and axilla. Total leukocyte count was 40,000 and eosinophil was 34%. So she was diagnosed with DRESS and treated with intravenous depot methylprednisolone. Lamotrigine was withdrawn, and it was thought or diagnosed that lamotrigine is the etiology behind DRESS, but levetiracetam was continued. Ultimately, she was recovered, discharged with oral prednisolone, and prednisolone was continued for 6 months, finally omitted. Next is third episode. She had a cut injury at around January 2017, started coamoxiclav, but on day 3, high-grade fever with macular rashes was developed with severe itching. And day 5, the coamoxiclav was prescribed. She was treated with oral prednisolone for 7 days, along with cetirizine. Fever was subsided by day 7 and rash subsided by day 9. Then, fourth episode, as she was working in a microbiology lab, exposure to some specific chemicals in that lab, within 10 to 20 minutes, there is urticaria, hives, along with she felt dizzy. So blood pressure was checked. It was 70, systolic blood pressure was 70, diastolic blood pressure was not recordable. So she rushed to hospital emergency, and she was resuscitated with adrenaline and other anaphylaxis medications for anaphylaxis. Again, December 2020, she had a road traffic accident, took cefodoxime specifically along with paracetamol for pain relief. She was afraid of taking different NSAIDs due to the fear of this type of drug allergy. And after 5 days, again, with cefodoxime, rashes with fever was developed. It was treated with, again, prednisolone and levocetirizine for 7 to 10 days. And it that reactions, rashes with fever, was subsided by 10th day. So with this history, when we are asking some other history and clinical examinations, so these are the other important points to mention. So at present, she had no symptoms suggestive of any atopic disease. Medication history is she is on cyproterone acetate and ethinyl estradiol fixed dose combination for once daily to treat her polycystic ovarian syndrome. And these medications she was taking for last 15 years. There is no history of any pediatric vaccine allergy. She took hepatitis B vaccination and influenza vaccination very recently. And with those vaccines, there were no events. There was no event. So no significant social history, family history, personal history, and food history. These all are important while evaluating a case of drug allergy. And finally, clinical examination also done and no abnormality was detected. So finally, we had advised her to take COVID-19 vaccine with vigilant monitoring during immediate period and follow-up post-vaccination period. And we had assured her that there is very less chance and there is no contraindication to COVID-19 vaccination. So following a few slides, we will try to cover the rationale behind this advice. So first of all, if we go by this diagram, we can see 4 pictures. I had purposefully not write that what type of hypersensitivity suggestive of which picture, but now you can see the cursor, I think. So let me, yeah. So this diagram where we can see the mast cell and the Ig receptor is there. Ig receptor, we all know that Fc epsilon type of receptor, and when the Ig antibody binds with that Fc epsilon receptor and finally one allergen enters and that allergen binds with Ig antibody, and that causes the release of different mediators and histamine specifically. So this is the mechanism behind type 1 hypersensitivity. So this diagram suggests that type 1 hypersensitivity reaction. And we have a fear that whatever immediate hypersensitivity reaction, they are type 1 hypersensitivity reactions, and we have a fear of COVID-19 vaccination that it can cause very negligible portion though type 1 hypersensitivity reaction, and that is why it is recommended to observe patient post-vaccination for at least 15 to 30 minutes. So most commonly, this is the type 1 hypersensitivity reactions. And what is important to know, whatever episodes we had already discussed, only the 4th episodes when that doctor has some anaphylaxis reaction while working in the lab due to exposure of some chemical and ultimately landed in a hospital emergency with hypotension and urticaria. So that picture is collaborating with this type 1 hypersensitivity reaction. Below that, this we can see, this is the type 2 hypersensitivity reaction. And type 2 hypersensitivity reaction is mostly cell specific. So cell specific, they are a very much cell specific reaction. So mostly they are, the damage happens at specific cellular level. And these are the three important mechanisms by which type 2 hypersensitivity reactions happen. So number one, when we can see these are the antigen which binds at the outer surface of the cell, and when it was the IgG molecule antibody attached with that, and they cause some attraction towards the natural killer cells, and the natural killer cells attached with that and kill the target cell. It can be done by the macrophage also. So this is one mechanism of type 2 hypersensitivity reaction. Otherwise, again, in the cell, we can see the antigen is bound where immunoglobulin G attached, and that cause, here we can see the FAP portion attached with the antigen, and FC portion is there, which stimulates specifically the complements, and that starts with that C1 pathway from C1 to again different complements activated, and ultimately the target cell is killed by this complement mediated lysis. So this is one mechanism of type 2 hypersensitivity reaction. And another is that, though it is least discussed, but this is an important entity of type 2 hypersensitivity reaction, that is the receptor specific autoimmunity that interferes with signal transduction. So in case of myasthenia gravis, the acetylcholine receptors are there. Now, instead of binding with acetylcholine, if the antibody binds with that, and that causes the interference with the signal transduction, and by that mechanism, the disease like myasthenia gravis happen. So this is one example of type 2 hypersensitivity reaction. And another example is just opposite of this type of reactions, that is the Graves' disease. So in the TSH receptor, the TSH will not bind. Some receptor will be, some antibody will bind to that particular receptor, and that causes some stimulation to that TSH receptor, and again the signal transduction becomes interfered. So these are the examples of type 2 hypersensitivity reactions. Very commonly this happens to drugs like penicillin, when the penicillin acts as an antigen, bind in the outer surface of red blood cell and attract one immunoglobulin G, and that causes ultimately the stimulation of the complement system, and ultimately the RBC will be killed or destroyed by complement mediated lysis. So that causes autoimmune hemolytic anemia or hemolytic anemia with penicillin, and that is a type 2 hypersensitivity reaction. Again, if we can think that penicillin can cause granulocytopenia, thrombocytopenia, and the mechanism is same. So these all are the examples of type 2 hypersensitivity reaction. And if we again go back to the history, the episodes of our case, will not find any matching between type 2 hypersensitivity reaction and our other cases. Now coming to this picture, this one, so where some locally injected antigens bind with immunoglobulin, and that ultimately causes some local immune complex formation, and mostly they will activate the Fc gamma cells, Fc gamma receptors outside the cell, and which cause local inflammation due to the destruction caused by that immune complex deposit, which also increased the phagocytosis of the affected cell. And this is very commonly seen, and that is why initially it was also named as Arthus reaction, type 3 hypersensitivity reaction. Another name is Arthus reaction. Generally, we saw in case of serum sickness like illness. So this is the example of type 3 hypersensitivity reactions. The difference, one of the major difference between this type 3 and type 2 is, in type 2, they are more specific to some specific cells. But in case of type 3 hypersensitivity reaction, it is more generalized. So this is very important. And we will not get any, again, similarity with the different episodes of our case with this type 3 hypersensitivity reaction. Now coming to the last diagram, the type 4 hypersensitivity reaction we can see here. So naive T cell, when bind with some antigen, or when the T cell gets the knowledge from the antigen presenting cell about the antigen, and we can see that HLA molecule here and the T cell receptor, in between we can see the antigen, and there are multiple co-stimulatory ligands are there which have some role in dictating T cells, whether they will make a T helper 1 cell or Th2 cell and other T cells, other types of T cells, and ultimately how they will modulate what happened to the final pathway, that is the signal 3, what are the cytokines they will develop, and ultimately the cytokines will act on the specific cells like macrophage, and macrophage will activate, and that causes different types of reaction. So it can be Th2 mediated reactions also, Th1 mediated reactions also. So that depends on the final pathway, signal 3, that what type of cytokines they are producing. So we all know about the 3 signals. That is signal 1, that means when the antigen presenting cell is taking antigen towards T cells, let the T cell know about the antigen, and that is the signal 1. And then the signal 2, that means there is a bonding or relationship, or we can say the ligand is making between the antigen presenting cell and the T cell, and that is the signal 2. And signal 3 is the final pathway, the message, the cytokine released by that interactions happened in the signal 2. And that cytokine that is released, that will govern what type of reaction ultimately we will get. And according to that, type 4 hypersensitivity reactions can also be divided into different classes, like monocyte predominant type 2 hypersensitivity reactions, lymphocyte predominant, neutrophil predominant, or even the eosinophil predominant hypersensitivity reaction. So now if we can go back to our case, then we'll find, except that 4th episode, which is a pure type 1 hypersensitivity reaction, all the other 4 episodes, 1st, 2nd, 3rd, and 5th episode that happen to different drugs, they are type 4 hypersensitivity reactions. And only one evidence we got from the 2nd episode, that the patient was admitted with breast. So we can say that eosinophil predominant type 4 hypersensitivity reaction. So this is very important while we are taking history of drug allergy. It is important to know the type of hypersensitivity reaction, because that will give us the knowledge for our what to do in future. Because in case of type 1 hypersensitivity reactions, that is the only case where we have an option like desensitization. But all the non-type 1 hypersensitivity reactions, like type 2, type 3, type 4 hypersensitivity reaction, they cannot be treated with desensitization procedure. So this is very important to understand what type of hypersensitivity reactions the patient is having. And from a detailed history taking, we can have that knowledge that this patient have this type of hypersensitivity reactions. We often prescribed drug allergy test, mostly the skin prick test. But this skin prick test only can detect those allergic reactions, those hypersensitivity reactions, which are type 1 hypersensitivity reactions. Skin test for drug allergy could not detect type 2, type 3, type 4 hypersensitivity reactions. So generally, if we can have the history properly, then we can have that power not to burden our patient with unnecessary testing, like drug allergy test for skin prick, or even there are some costly tests like drug specific IG test. So that is also not needed, because that will not detect the type 2, type 3, and type 4 hypersensitivity reaction. One test is available to detect T cell mediated drug reactions, which is also known as lymphocyte transformation test, or LTT. But this test is not that much available. Specifically in Kolkata, it is not available at all. So this test can have some overview that I might have a potential to be allergic or type 2, type 3, type 4 hypersensitivity reaction to some specific drugs, and we can avoid those drugs. We could have some alternative drug if we have type 2, type 3, and type 4 hypersensitivity reaction. So this is an important issue. But as we are talking about now, the COVID-19 vaccine suitability or safety in patients with some drug allergy reaction. So first of all, there is no doubt in that as this particular patient having mostly the type 4 hypersensitivity reactions with some specific drugs and no reaction, no history of other vaccine allergy like influenza and hepatitis B, mostly there is a very less chance of having type 1 hypersensitivity reactions. And that is why we had allowed that patient to take COVID-19 vaccine. So now coming to, for any agent of drug allergy, we need, while giving some opinion regarding whether that patient can take that particular vaccine or not, we need to go through the components of that particular drug or vaccine. So we need to identify the allergenic or immunogenic components of the vaccine. Apart from that adenovirus, ChAdOx1 vaccine includes excipients like Polysorbate 80, amino acid L-histidine, ethanol, salt, sugars, and buffers. So among them, Polysorbate 80 is such an excipient which has also an allergenic potential. And which type of allergenic potential? Mostly the type 1 hypersensitivity reactions. And Covaxin contains different inactive ingredients like aluminum hydroxide gel, TLR7 or 8 agonist, 2-phenoxyethanol, and phosphate buffer saline. Where vaccination is contraindicated. So if there is a prior systemic allergic reaction to the COVID-19 vaccine, so I was taking a Covishield vaccine, and at that time of taking Covishield vaccine, I have a systemic allergic reaction, anaphylaxis, or some other type 4 hypersensitivity, type 2 hypersensitivity reactions. Mostly the type 4 hypersensitivity reactions or type 1 hypersensitivity reactions, it is better not to take Covishield in the second dose. And if at all needed to take the second dose Covishield, in case of type 4 hypersensitivity reactions, serious type 4 hypersensitivity reaction, there is a totally contraindication to take the same vaccine, that is Covishield. We should take the other vaccine. But in case of type 1 hypersensitivity reaction, there is a provision that if we can follow a desensitization protocol and we can take the same vaccine or not. Apart from that, if allergic reaction to a component of the vaccine, like Polysorbate 80, so I have a allergy, known allergy to that particular Polysorbate 80, which is also found in different vaccines, different drugs, then I should not take Covishield. So this is very important. These two are the only condition where we should not take COVID-19 vaccine. There are some special precautions where we should be very cautious. Number one, history of immediate anaphylaxis to multiple different drug classes with the trigger is unidentified. And sometimes this may also indicate pig allergy. That means polyethylene glycol allergy, because polyethylene glycol is such an excipient or sometimes a active drug, we know the laxative, that have a potential to produce type 1 hypersensitivity reaction. History of anaphylaxis to a vaccine or some injected antibody preparation or a medicine likely to contain PEG, that is polyethylene glycol. One of the most common example containing polyethylene glycol is the depot steroid injection. And here I want to emphasize, as we are taking the history of this case, we found that the second episode, the DRESS syndrome, to that particular patient was treated with depot methylprednisolone. So at least we can convince ourselves like that our patient is not allergic to depot steroid injection, and therefore she does not have allergy to polyethylene glycol. Another important issue where we should be very cautious, that is the idiopathic anaphylaxis. We don't know about the cause of the anaphylaxis. Like our case, we know the cause of that fourth episode, which was a typical anaphylaxis. We know that the stimulant was some chemicals that was used in the lab and that enters through the inhalational route. So we know the cause of the anaphylaxis. So it was not idiopathic anaphylaxis. In case of idiopathic anaphylaxis, we should be cautious. And these are the case when we need to discuss with some specialist like clinical pharmacologist and allergist. We need to consider the possibility of polyethylene glycol allergy. In our country, as we are using the Chadox vaccine, Covishield vaccine, the Polysorbate allergy, the possibility of Polysorbate allergy we need to consider. And we need to observe this type of patients more duration after vaccination. And that can be 2 hours, up to 2 hours. It should be more than 30 minutes and up to 2 hours, it is better. There are some comments like that. Some patients may benefit from pre-treatment with antihistamine, but it is important to note that if we are prescribing antihistamines as a pre-treatment, it may mask the initial symptoms of a type 1 hypersensitivity reaction or some other type of drug allergy reactions. So we all should have a consensus, and this is very true, that early detection and prompt treatment is the key to treat anaphylaxis. Anything that has been delayed, so that could be fatal. So we need to prevent that delay. So it is not a wise decision to mask the initial symptoms of a reaction by giving antihistamine. These are the clear-cut case in background of allergy. There is no question, no thought, no doubt. We can proceed with vaccination. Number one, previous allergic reaction. It may be anaphylaxis also to a food, insect sting, and most medicines where trigger has been identified. We know the trigger, we know the medicine, we know the excipient. So we can proceed with vaccination. If it is not matching with that particular vaccines or vaccine excipients. Family history of allergy, no question of any doubt, we can proceed with vaccination. Previous non-systemic reaction to a vaccine, hypersensitivity to drugs like NSAIDs, aspirin, ibuprofen, even the patients with mastocytosis, that they can take COVID-19 vaccine. Now, a little discussion to this Polysorbate 80, as it is an important excipient in our Covishield vaccine. So this is a synthetic non-ionic surfactant biologically and possibly pharmacologically active. It has some property to alter the pharmacologic properties of that particular drug or vaccine. We need to understand that what are the formulations that include this polysorbate 80. So formulations that include polysorbate 80 as excipients are amiodarone, vitamin K formulations, anti-cancer drugs like etoposide, docetaxel, various vaccines like influenza, hepatitis B, as we took the history of this particular lady who had taken influenza vaccination and the hepatitis B vaccination without any reaction. And that is one key to think that most probably this particular lady does not have any polysorbate 80 allergy. It is also present in some protein biotherapeutics, erythropoietin stimulating agents, or phosphoaprepitant. So it is important to note why this is necessary to know. If a patient seeks your advice and whether he or she will take COVID-19 vaccine, and you will get a history that the particular patient have a previous history of type 1 hypersensitivity reactions with amiodarone loading dose. So then you should be a little bit more cautious, because that type 1 hypersensitivity reactions with amiodarone infusion, that can be due to amiodarone, or it can be due to the concomitant presence of excipient like polysorbate 80. So this history is important. This history will tell better to take for that particular patient Covaxin instead of Covishield, because Covishield contain polysorbate 80, but Covaxin not contain polysorbate 80. So this is the important fact we should remember. And another important issue, the cross reactivity between polyethylene glycol and polysorbate. They have a cross reactivity. So polysorbate 80 derived from polyethoxylated sorbitant and oleic acid. It is a common emulsifier and stabilizer in the food industry and excipient in the medications and vaccines like influenza, hepatitis B, human papilloma virus vaccines. And this is the excipient of Covishield allergy, Covishield. So now, if a patient has a history of influenza vaccine allergy or hepatitis B allergy or HPV vaccine allergy, then we should be more cautious while choosing Covishield. In those particular patients, it is wise to choose Covaxin. And this polyethylene glycol and polysorbate, they share and same allergenic epitope. So sometimes a known patient of polyethylene glycol allergy, like if a patient having allergy to some laxatives containing polyethylene glycol, or a patient having allergy with depot medroxyprogesterone or depot methylprednisolone, then also we need to consider Covaxin ahead of Covishield. So these are the important issue. And immediate hypersensitivity to polyethylene glycol with skin test, cross-reactivity to polysorbate 80 has been reported in multiple studies. But whether it is that much clinical relevant, that is unclear. So we need to consider this. And this is a beautiful guideline from UK, their green book. So if a patient visited us with a possible allergic reaction to first dose of COVID-19 vaccine, then this is the important questions. That is number one, whether this is an allergic reaction to first dose of COVID-19 vaccine. We need to be very much clear about that. Then the temporal relationship. So did symptoms begin within 2 hours of vaccination? So if it is yes, then it is the immediate type allergic reactions, type 1 hypersensitivity reaction. So again, then if it is type 1 hypersensitivity reaction, then we need to see whether it is this includes anaphylaxis. So symptoms suggestive of anaphylaxis, systemic symptoms. If it is yes, then we need to be very cautious while choosing the second dose of COVID-19 vaccine. And sometimes we need to prepare our patients to follow some desensitization protocol. But if it is the only local or injection site rash, local reaction, then that particular patient can have the second dose using the same vaccination in any vaccination setting. But again, we need to observe for 30 minutes at least, and preferably 2 hours. Now, if it is not an immediate type allergic reaction, if it is a delayed urticaria or sometimes angioedema, delayed reaction, then also we need to see whether it is a local reaction. If it is local reactions, then we can follow the same protocol. If the reaction is self-remitting or resolved with oral antihistamines, there we can have the second dose using the same vaccine and in any vaccination setting. But here is the condition where we can choose antihistamine as a pre-treatment agent. You may ask why in this case, whether it will not mask. Here we are talking about delayed type of reaction. Here we are not talking about the type 1 hypersensitivity reaction. You can see in this box, they are not mentioning to give the pre-treatment with non-sedating antihistamine, because here we are concerned about that type 1 hypersensitivity reaction. But here we are not concerned about type 1 hypersensitivity reactions. We are concerned about type 4 hypersensitivity reactions, delayed type of reaction. So there we can use antihistamine as a pre-treatment agent. But if the reaction, the late reaction, and it is severe, it requires medical attention. So that is the case where we need to seek advice from allergy specialists, and preferably we should switch over to other vaccines that is not matched with excipients also. So this is very important to consider, because type 4 hypersensitivity reaction cannot be reversed by desensitization protocol. And this is again a beautiful chart where we can see this is the COVID-19 vaccine allergy assessment hub. So anaphylaxis to COVID vaccine, then skin test. What we should do, we can do a skin test with vaccine, skin test, or we can have some direct provocation test with some excipients. This PEG is important for Pfizer vaccine. This PS80 or Polysorbate 80 is important for Moderna vaccine, and this tromethamine is important for, Polysorbate 80 is important for Covishield vaccine, Chadox vaccine, and tromethamine is important for excipient for Moderna vaccine. So depending on the vaccine type, we can choose what excipient we should do the test. So if the test reports are negative, we can have the vaccination in the hub, or if it is positive, then we should use other alternative vaccine, or in case of anaphylaxis, as it is a type 1 hypersensitivity reaction, we can consider desensitization with a protocol. When we have a suspicion of pig allergy, polysorbate allergy, or tromethamine allergy, we need to do the skin test or direct provocation test with the relevant excipients. So if it is negative, then we can vaccinate in any setting. So this type of suspicion could arise from the prior drug history that already we had discussed. I want to emphasize one very important excipient here mentioned, that is tromethamine. Tromethamine is an important excipient that is also present in one very commonly used insulin preparation, Lispro mix or Lispro insulin, that is Humalog insulin. So if a patient having allergy to Humalog insulin, it is better not to choose Moderna vaccine for that particular patient, because maybe that particular patient have allergy to tromethamine. Now, if the test is positive, then again the same protocol, and we need to choose other vaccines considering the different excipient. And where there is a confirmed anaphylaxis to any vaccine that requires some adrenaline and ITU management, idiopathic anaphylaxis, and the cause of anaphylaxis is not known. Patients with systemic mastocytosis with recurrent anaphylaxis history, so there we should have a proper allergy workup depending on the history, and it is important to vaccinate in any setting if workup is negative for that particular vaccine, and sometimes vaccinate in the hub if previous anaphylaxis was severe. The second vaccine, we should be very cautious. But these are the very rare area. The polyethylene glycol allergy, the clinical history is most important. So patients with history of anaphylaxis to the most common drug culprits like depot medroxyprogesterone or depot methylprednisolone acetate or macrogol laxatives, or in India we have lots of polyethylene glycol containing laxatives. The severe allergic reactions to multiple seemingly unrelated drugs, then also we should consider this pig allergy, because pig can be a excipient to those particular drugs. So where routine allergy tests do not confirm the specific drug as the culprit, we need to have a thorough history with that pig allergy. In our country, why pig allergy is important? Though pig is not an excipient in the Chadox vaccine or Covaxin, that is Covishield or Covaxin, but this pig and Polysorbate. The Polysorbate is an important component or important excipients of Covishield vaccine. They share the similar antigen epitope. So that is why it is important to know about the pig allergy also, because there may be a chance of cross sensitivity. Now, this is an important fact also need to consider, and this can allay the anxiety of many patients. So negative pig skin test in 8 patients with a history of hypersensitivity to Pfizer and Biotech and Moderna vaccine, successful administration of second dose of the same vaccine among most of them, that 7 out of 8. So this was published in one literature. But there are some unanswered questions for how many patients pig or polysorbate relevant as allergens in these vaccines. With all pig allergic patients, that is sensitized to different molecular weights of pigs that react to the vaccine that contain pig 2000 in a very small quantity, how many pig allergic patients will react to Polysorbate 80 due to that cross reactivity? And standardized skin test protocols and in vitro test are a work in progress, but still it is not developed that much. And we should have an individualization in the testing regimes. And what should we do in case of unexplained anaphylaxis? Or we can say the idiopathic anaphylaxis that we don't know. Here I want to mention one point, though with a controversial sign also, that if we go by the constituents or present in the Covaxin, one of the important excipient is that TLR7 and 8 agonist in the dose of 15 microgram. Now, it is clear that if a patient have known severe allergy to any component of Covaxin, they are not advised to be vaccinated with Covaxin. Otherwise, all the patient that can take this vaccine. So individuals with a history of severe allergic reactions not related to vaccines or any injectable medications containing these agents, like environmental allergies, allergies to food, pet tender, venom, latex, they may still get the vaccinated. Even the patients who has allergy to oral medications, family history, they also can take this vaccine. Here I just want to mention this point that injectable medications, here we should be focus on that particular injectable medication. We try to see the relationship, specifically the relationship of that particular excipients present in those injectable medications. Otherwise, blanketly saying that as the patient having allergy to that injection penicillin, this patient will not eligible to take Covaxin. This is a wrong message. So this we should be very much clear about that. And another important issue that I want to mention regarding the Covaxin, but again I am telling this is a controversial remarks though. The TLR7 agonist, if we go by one randomized control trial, double-blind randomized parallel group trial. So we found that in patients with allergic asthma, TLR7 agonist could potentially reduce the allergen responsiveness by stimulating the type 1 interferon responses, and that causes the downregulate to the dominant Th2 response. So we all know that if there is more type 1 interferon, so what happened? The Th2 response will become Th1 response. So whether this TLR7 agonist can act as an agent which reduce the chance of allergy, we don't know the answer yet, but we should wait till the reports from AEFI, adverse effect following immunization of our program of our India, published some data regarding the Covaxin regarding the high incidence of hypersensitivity reactions or other types of allergic reactions who are taking Covaxin vis-a-vis who are taking Covishield. I think there are lots of data in the AEFI, under AEFI. So we should have that data maybe a couple of days or months, within couple of days or months. So that data can give us a clear understanding that which vaccine has lesser chances of getting anaphylaxis. But this trial should be read with a pinch of salt, because we don't know this particular dose is either matching with the dose of TLR7 agonist used in the Covaxin as an excipient. Now coming to the last part, the key message of COVID-19 vaccine and allergy. This is a we should be very clear cut about this key message. Number one, unless the patient has a history of an allergic reaction to any of the vaccine components, there is no contraindication to the currently approved COVID-19 vaccines. allergy to drugs, food, insect venoms, or inhalant allergens like house dust mites, pollens, animal dander, molds is not a contraindication for any vaccines, including COVID-19 vaccine. We should observe after vaccination, and that should be at least 15 to 30 minutes. In case of allergic reactions, in background of allergic reactions, any type of allergic reaction, drug allergy, pollen allergy, this observation time will be little bit more, maybe up to 2 hours, 30 minutes to 2 hours. Some people require longer observation and monitoring of vital signs, we had mentioned, that is patients with history of severe allergic reactions, uncontrolled asthma, muscle disorders. So they should be monitored at least for 2 hours. Severe allergic reactions can happen even in people without history of allergic disease. So this is a very important message. Even if I don't have the history of allergy, I am susceptible to develop type 1 hypersensitivity reaction, anaphylaxis. But the chance is only 0.00025%. So very less. And that percent is equal among the atopic subject and among the non-atopic subject. So anaphylaxis is a life-threatening condition, but it resolves without sequel. And what is required? We need a prompt identification of the symptoms and quick management with appropriate drugs like adrenaline. So patient who had a severe allergic reactions after the first dose of COVID-19 vaccination should be referred to the allergy center for the workup or in the clinical pharmacology OPD of any hospital. Unless it is confirmed by an allergy specialist or clinical pharmacologist that the vaccine did not induce the allergic reaction, they should not receive the second dose of the vaccine. It is important to understand the type of hypersensitivity reaction to particular vaccine. If it is a type 1 hypersensitivity reaction and a severe one like anaphylaxis, we should follow a desensitization protocol before giving the second dose of that same vaccine. Otherwise, we need to consider changing to the other vaccines which not contain the similar constituents. In case of type 4 hypersensitivity reactions, if it is severe, there is no second thought. We should choose a second dose of different vaccine. In case of mild reaction of type 1 hypersensitivity reactions or type 4 hypersensitivity reaction, we could have a thought to choose the second dose, and we should choose the second dose of that particular similar vaccine with proper monitoring. So vaccine components are currently investigated for the potential allergenic or immunogenic components. So we need to see, an allergy clinic should confirm the hypersensitivity reactions or allergy backgrounds of that particular adverse reactions to the vaccine. So how they are related, whether they are true AFI, those vaccine allergy is true AFI or not, we need to understand that. And for that, we need to apply our clinical pharmacological principles, and that is most important. So COVID-19 vaccination center and staff should be prepared to recognize the symptoms of anaphylaxis as early as possible, promptly treat anaphylaxis with epinephrine, start adequate intravenous volume substitution, activate further emergency medical services while continuing to monitor or treat the patient. And here it is important to also know the drug history, medication history of that particular patient while treating anaphylaxis. If a patient is already on beta blocker, it is important to be more vigilant while following the anaphylaxis protocol. Specifically, the patients who are on beta blocker, they sometimes requires glucagon intramuscularly. So these are the important issue. And while giving glucagon intramuscularly, it is also important not to lie down the patients in the spread position, supine position, because glucagon induce emesis, and that emesis can cause some aspiration. So it is important while giving glucagon injection to make the patient in one side. So these are the few important points we should keep in mind. But ultimately, we need a partnership. We should have a team approach, partnership between academia, regulatory agencies, and vaccine producers to establish an efficient way for hypersensitivity or allergy workup, establish a safe way to administer the second or booster dose of vaccine in patients who had severe allergic reactions after the first dose. And we need to establish safe protocols of desensitization in patients who had severe allergic reaction after the first dose. This is very important, desensitization. Even in one case, if we successfully do the desensitization, then that will be the protocol for future desensitization. Because till date, we don't have any specific desensitization procedure. But again, we need to emphasize that desensitization is only possible if it is type 1 hypersensitivity reaction. So first of all, we need to understand what type of hypersensitivity reaction the patient is having and answer the scientific questions about the mechanisms of these reactions. That is why very important. And we need some diagnostic and preventive allergy workup in patients with severe allergic reactions after the first dose of COVID-19 vaccine. We should have multiple procedures, testing like skin prick test, intradermal test, some test like basophil activation test, mast cell line assays, lymphocyte transformation test. These are very important. And we also need to validate some biomarkers, can be clinical, immunological, to predict and follow for follow-up of severe reactions. To see some blood test like tryptase level, whether it is possible to check tryptase level, which could be a very important biomarkers. We need to see elaboration of the protocols for modified dosing of the second or booster dose COVID-19 vaccination in allergy clinic and for desensitization or immunotherapy to COVID-19 vaccine. So desensitization protocol for the cases who suffered from COVID-19 vaccine related anaphylaxis. And sometimes we need to recommend potential alternative COVID-19 vaccine in case of confirmed allergic reactions, specifically the severe confirmed allergic reactions, which are type 4 hypersensitivity reactions to a first COVID-19 vaccines. There is no other way. For type 1 hypersensitivity reactions, we can follow that desensitization procedures. So these are the research challenges and questions. Who is at risk of developing severe allergic reactions to any of the new COVID-19 vaccines? We need to get answer. And the AEFI data could provide this answer to us. What is causing sensitization to an ingredient of a COVID-19 vaccine? What are the potential immune mechanisms other than Ig-mediated hypersensitivity reaction? What are the cause of different other type 4 hypersensitivity reactions? What is the impact of previous infection with SARS-CoV-2, other coronaviruses like SARS-CoV-1 or MERS-CoV, or previous vaccination with other agents on the individual risk? So these are few important questions, and we need to go through detailed research activities to find those answers. So these are my references for this particular presentation. This EAACI position paper is a very important one. Adverse reactions to COVID-19 vaccine, a practical approach. We got multiple information from that also. This is an important document, that is the vaccine excipient and media summary. So from that, we will know about different vaccine excipients. We can have a history checking. COVID-19 Green Book Chapter 14A is an important chapter to read, to decide regarding what to do if a patient having COVID-19 vaccine allergy at the first dose. So these are the important references, and I'm really thankful to my professor and head of my department, Professor Shantanu Munshi, because he was leading the investigations to that particular case, what I had presented in front of you. And along with him, I was there in doing the investigations and clinical examinations to that particular case. Finally, I personally got calls from at least thousands of my patients who has a history of allergy and asking me some allergy, that whether I can take vaccine. And they are very confused regarding the COVID-19 vaccination, as they have some allergy. So I hope that with this information, what I had presented in front of you, this type of confusion will be removed. With that, I thank you all. Special thanks to my professor, my mentor, my guide, that is Professor Shantanu Kumar Tripathi sir, who had introduced me to this field of clinical pharmacology. And he is one of the pioneers in India regarding COVID-19 vaccine research. So thank you all. Thank you for this patient hearing. Thank you.